Dr. Matt Ryan. I'm one of the faculty members from the Department of Emergency Medicine and one of the committee members for the write this down, I Promise Campaign Physicians Initiative. Just a little historical context about what we're about and why we're here. Something in the I Promise campaign that was initiated over a year ago with regard to what we can do as physicians in terms of improving how we take care of our patients and how we interact with our colleagues, how we talk to each other, verbal, nonverbal communication, in a way to just improve the way we deliver health care, giving more responsible, safer patient care, and just making the whole process more enriching. We're going to have two speakers today. They're going to tell you their story, and then afterwards we're going to open it up to the floor for comments and thoughts and anything like that.
Sullivan. I'm a registered nurse here at Shands, this time for 14 years. I worked, when I first got out of nursing school in 1900, and I will tell you what it was. It was 100 years ago. And I can tell you a significant difference in the communication with the physicians then versus the communication with physicians now. I can tell you it's a significant difference. It's a significant improvement, in my opinion, having seen the way it was versus the way it is now. What I think is working now for us, I work on 64, which is an internal medicine floor, and telemetry. And what I think is working now is, since we started gate rounds, and the nurses are much more included in the rounds process whenever possible. We realize when a nurse has 5 or 6 patients, you're not always going to be available when the doctors are making rounds. But they have been identifying a general time frame when they will be making rounds, so we try to make ourselves free to ask questions, to give input, to give comments from the patients that perhaps they didn't tell the intern when the intern made pre-rounds, okay? So I think that that's working very well, and I hope to see that continue as well as it has. The other thing that I see is that the physicians, the interns, and the medical students are all open to questions. When they're talking on rounds, I've never had a problem where I've said, do you mind if I ask a question? They always take time to answer the question. They always take time to make sure that I understand what's going on, because I'm not a physician, I'm a nurse, but I see a different side of the patient than perhaps that the physicians do. And I think the other thing is that included in that is the willingness of the doctors and the attendings, the residents, the interns, the med students, the pharmacy students, the PharmDs are all willing to teach, and that's been a really big improvement from my previous experience at Shands versus the current experience. From a nursing perspective, what I think we can improve for you and help to improve the communication to you, the physicians, is that we have tried this, and it's starting to work, is that when it's not an urgent question that needs to be answered, we're trying to increase the time that the incidence of texting you. The other thing that I think would really help to improve things is if you tell a patient something, tell us too. I can't tell you how many times I've had a patient say, well, the doctor told me I could eat, but we don't have an order for that, and the patient saying, well, it's almost lunchtime, why didn't I get breakfast? And so just, if you're going to make some changes like that, just tell us what they are on your way by to the next patient, so that we'll have a way of answering the patient. It doesn't give the patient a lot of confidence if the doctor's saying something but the nurse doesn't know and doesn't have an order. It kind of erodes the confidence the patient has in the nurse.
The nurse that's going to speak for us is Michelle Plourde from the Department of Emergency Medicine.
Our nurses are not just 22, 23-year-old college graduates, but they are often people who have come from other professions, and they are larger than nursing, if that is even possible, because the world of nursing is so incredibly huge. And that's one of the things that I have enjoyed. We as nurses, we are taught to be autonomous and educated advocates for our patients. We are specifically taught not to be subordinate to people. We are specifically taught to be members of a team. And that team includes physicians, it includes respiratory therapists, it includes, for the love of goodness, housekeeping. I mean, it really does. And if you've not seen a housekeeper clean a room that just had a patient with active TB and upper GI bleed, holy cow. I mean, it's amazing the amount of work that goes into taking care of human beings, and that's what we do. So we are expected to be educated in pharmacology and assessment and disease process, and we are also taught to ask questions for the love of learning, but also because we have to ask questions of physicians if we don't understand why we're doing something. If we don't understand why a patient's getting a medicine or going for a procedure, we have to ask. It's what we do as nurses. Please don't be that physician that the nurse is sorry to have to call. Because you hear nurses say that, I'm sorry to have to call you. We're not sorry to have to call a physician. We're not. It's what we do. We call a physician if we can't settle a problem. But don't be the physician that the nurse is sorry to call. And in turn, as nurses, I think we can gather the information that the physician is going to need and to have that information readily available so that we're not calling without and wasting anyone's time, our time, their time, human beings, strangers' time. So, thank you all very much.
At this point in time, I invite anybody who has a thought or comment to stand up and say something.
That over the years, from the surveys that are given to patients, how so easily issues with regards to physician and nursing relationships are recognized by patients, how sensitized they are. And so when I look at those surveys in the past, and I can see very clearly that patients do sense when communication is not existing. They do sense when the team does not work very well together, and they will report back.
So probably about last year on 80s, what we do is we do an orientation within the first day that they come. And what that's for, it really is to welcome them. And it's to tell them a little bit about the unit, what kind of things might be helpful for them. You know, everything from how to get to the bathroom and the codes and those simple things to expectations with discharge orders and that kind of things. But I also spend a lot of time talking about our patient satisfaction and their role in that and how proud we are of them.
Every time we have an incident in terms of a patient outcome, we call this AAR, After Action Report. And we discuss what went well, what went wrong, and the things that went wrong, what we can do to improve it. And we can do the same thing here. We have codes and stuff on the floors. We can do the same thing.
Chad, I'm from 64, and I would just like to say that rounds, I think, have changed patient care. Gata rounds have changed patient care on our floor. And I think when we did try it, it went so great that I guess the thing I'd like to ask is, now that we've tried it and it worked, why isn't it being done by all teams? Like, it seems like common sense from where I am. If we tried it and it went great, and it helped us, but more than that, it helped those folks that we care for in the bed, because
Gata Runs is basically based on athletic principles. 3 principles: playbooks, everybody knows what they're doing. Second is customer-supplier relationships. One of the key ones is doctors understanding that nurses are our customers, and that if we don't supply accurate and clear orders, they can't manage our patients properly. And the third in the game films, and that is what went well today and what could we improve. In the morning, the team resident actually schedules the round so we can tell the nurses within a 5-minute period when we will be at their bed, so that they can work their schedule out, so that they can actually actively participate. And then the other thing is we have a huddle. So we always keep it a circle, and the nurse needs to be part of that circle. Well, when we started, the nurse always stepped behind the circle and wouldn't come in. Now they jump right in there, and they have a tremendous amount to say. And in many cases, they provide information and suggestions that dramatically improve the care of our patients.
What I would love to say to every nurse in the whole hospital is I think we just have to eliminate the us versus them mentality of the entire hospital. It has to be a we for the patient. So, I mean, I think that's what the communication and the rounding, and if it's not happening on your floor, it should and will. And you know, just getting rid of the us versus them mentality, I think, is going to fix a lot of the communication problems, a lot of the the fear problems, and a lot of the problems that lead to poor patient outcomes.